Dr. Hurtado, thank
Yes.
you for joining us and sharing your experience in amending the international guidelines and recommendations to reflect the local needs in Mexico.
My pleasure.
So I might start by asking you, at
Yes.
which stage of the disease is CML usually diagnosed in Mexico?
Well, I think we have the figures completely same like the people from Africa, particularly in chronic phase. 95% of the cases are in chronic phase. Around 5 to 10% of the cases arrive with us with a very bulky disease. So it means very high leukocyte count, anemia, and big splenomegaly, giant splenomegaly. And the patients really looks like very ill patients. We are seeing that in Zambia, in Africa, patients looks the same thing. The response is not the same, but mostly are in chronic phase. We are published in around 15 years ago in ASH that some of those patients who looks very ill with more than 1 year of the clinical signs and symptoms, they have chromosomal abnormalities additional to the Philadelphia chromosome that confers a very bad prognosis and is being shown in survival.
And so which scheme of TKI therapy can you use in Mexico? First, second, eventually third line therapy? And is this available for all of your patients?
Well, you know, we are affiliated to the Max Foundation program in Mexico City for most of the patients who does not have any social security system. And we are joining around more than 1,000 patients distributed in some hospital. Here in my center, I have around 160 patients who are integrated in this program, and they have only access to the imatinib therapy for today, tomorrow, and always. Thus, we have no choice for second or third line therapy at the beginning of the treatment.
I understand.
Some private patients that we are seeing here in the clinic, they have access maybe for some reasons to initiate it with second line therapy, particularly women that wants to be pregnant for the near future, but the other patients are not able to have second line or third therapy for the beginning of treatment.
I understand. How do you make decisions on switching therapy, and what determines your choices?
Well, switching, it means to move to second or third generation therapy, but the switching in our cases is back to the past. It means that we are using again with busulfan or Idrea for some patients because we have no matter to make a switch with other therapy. We are doing is mainly increase the dose for those patients who does not have a response at the 3 and 6 months of the normal 400 milligram daily. And when we see those patients with partial or minimal response, are increasing as maximum dose of 800 milligram and see what is happening in the next 3 months of the increase of therapy. This is the only switch that we have chance. So we have seen, interestingly, that we are adding thalidomide in some patients with a very, very interesting response that is making some pharmacologically, I think, interact with imatinib, and curiously, they respond to complete response. I mean, molecular response. The first communication of this therapy was done around 10 years ago in ASH, and we are doing the review of these patients who are with thalidomide and imatinib with very encouraging results. But of course, you know, the criteria, this is an international criteria for switching to second or third line therapy, depending on the molecular response, of course.
Of course. So how frequently can you monitor the patient's response to TKI therapy?
Well, it has been during the last 18 years ago that we have the chance to have the molecular monitoring through the PCR every 3 or 6 months of the induction therapy for majority of the patients.
Okay. And are you trying to implement a TKI discontinuation program?
Yes, we have 3 years ago, we published in ASH a paper in the Congress that after seeing the results of the literature, in which most of the authors discontinuation is 100% of the dose, that we are doing as a matter of criteria, we are not following the European Leukemia Net. We prefer to do with the criteria of the NCCN, which includes 3 years only of the patients of the minimal for taking imatinib and 3 years of being in a complete molecular response 5 or undetectable. This has been our criteria, and we are we started with 50% of the continuation of the therapy, and in the majority of patients who are in chronic phase, who they have 400 milligram, and you know, we discontinue to 300, and after 1 year it continues with molecular response. We continue to the half of the dose, I mean 200 milligram, and the number of patients we treated and informed was at only 7% of molecular relapse after 2 years of follow-up. So at this time, we are making the cumulative results for see what is happening with this interesting schedule of discontinuation program. I think this is a very, very, very important for us, because it has only not only I think I mean a kind of decrease the resistance and improve survival, but also for economical reasons, to not have more expenses in this kind of patients. I think trying to optimize the treatment.
What do you feel the biggest challenge is in Mexico to implementing the international guidelines and recommendations to their full extent?
Well, I think the most important is to have access to whatever program for have second or third generation treatment, as it happens in other countries, and also the access for detecting another chromosomal abnormalities, as well as changes in the, of course, the chromosomal abnormalities. That means clonal evolution of disease. I think this is the most important for us, and to see the opportunity and fight with our government for having access to these opportunities that have in other countries, and we don't have it already.
It's very challenging. And so finally, what is the single most important aspect of clinical management of CML patients in Mexico that you would like all newly qualified hematologists to know?
I think first of all is detecting the disease in which of the phase is correctly allocated. Is the chronic phase, it should be received the correct dose of 100 milligram, and for those of course will be in accelerated phase, increase since the beginning the 600 or 800 milligram at the beginning. I think this is one of the most important aspects. And the second one is the following with the molecular response with PCR and detecting other chromosomal abnormalities and make programs for detecting which patients are candidates for decreasing the dose, not strictly stop therapy, but just maybe decrease slowly with the time.
Okay, Dr. Hurtado, thank you very much for talking with me. It's been a pleasure. And on behalf of the ICMLF, may I share with you how much we appreciate your work and your efforts. Thank you very much.
Thanks to you, my pleasure. Thanks, bye-bye.